Hello, welcome to the California Telehealth Policy Coalition webinar, Telehealth and Medi-Cal, What's Next After COVID-19. My name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy. We are the convener of the California Telehealth Policy Coalition. Next slide, please. The Telehealth Policy Coalition is made up of over 100 statewide organizations and individuals who are interested in advancing telehealth policy in the state of California. For more information about the coalition, please feel free to reach out to CCHP or to go to the link below for the coalition's webpage on CCHP's website. Next slide. A couple of housekeeping items today. So the objective for today's webinar is to provide an overview of recent Medi-Cal proposals for the Medicaid program in California regarding telehealth policy. We're also going to hear from different stakeholders' perspective on how these proposals will impact their constituents. There will be a panelist discussion on pertinent telehealth issues and principles that should guide implementation of telehealth policy post-pandemic and answer key questions on Medi-Cal telehealth policy considerations. Next slide. The agenda today, we will have a brief overview of the Medi-Cal telehealth proposals provided by Amy Durbin from CCHP. Our panel will be moderated by Blanca Castro from AARP, and we have a great lineup of speakers: Jen Alley from the Marriage and Family Therapists Association, Myra Alvarez from the Children's Partnership, Dr. Priya Batra from Inland Empire Health Plan, and Andie Martinez Patterson from the California Primary Care Association. Please note that all attendees are muted during this webinar. If you have a question for our panelists, please put it in the Q&A function. If you have a technical question about Zoom, please put that in the chat. So your questions for panelists should be in the Q&A function. Questions about technology should be in the chat function. Know also that today's webinar is being recorded and it will be posted later, a couple of days afterwards, on the coalition webpage on the CCHP website. And with that, I will now turn it over to Amy Durbin.
Thanks, May, and thanks everyone for being here. So I'm going to jump right into a brief overview of the administration's proposed Medi-Cal telehealth policies post-pandemic. So the overarching theme to the proposal is really a focus on ensuring synchronous or real-time live video telehealth. So it plans to treat all other modalities differently, but there are not many details on what that will look like. For instance, the proposal ensures payment parity, but just for synchronous telehealth only. And then it creates a separate and new fee schedule with different reimbursement rates and policies for asynchronous, store and forward, audio only, RPM, and all other virtual communications. And it gives DHCS the authority to limit the services provided through those modalities, and the providers able to utilize them. Also limits them to established patients only. In regard to FQHCs and RHCs, it does maintain the elimination of site restrictions, but only allows them to utilize synchronous telehealth modalities. Audio only and store and forward and other modalities would be completely eliminated. It also limits plans' ability to factor telehealth into their network adequacy plans to just synchronous telehealth as well. So it's helpful to put the proposal in context with pre-pandemic and during pandemic policies to really understand its impacts. So that's what the rest of the overview will look at. In regarding to the existing emergency flexibilities, the proposal really just codifies pre-pandemic policies related to synchronous modalities while expanding just a few existing flexibilities, such as removing the FQHC and RHC site limitations, adding RPM, and then including expansions for some services and a few particular programs like targeted care management, LEA BOP, and state plan drug Medi-Cal. The proposal really narrows its previous Medi-Cal policies pre-pandemic when it comes to asynchronous telehealth and what it refers to as new utilization management policies, which again are not defined. So not only does the proposal limit asynchronous and other modalities for Medi-Cal providers, it eliminates them completely for FQHCs and RHCs when previously asynchronous was treated similar to synchronous pre-pandemic, as well as allowed for FQHCs and RHCs. Limiting payment parity and establishing new patients to just synchronous telehealth modalities also conflicts with existing laws for commercial patients and creates an uneven standard for Medi-Cal. Next slide. So here's a quick visual of that comparison between the proposal and current and previous Medi-Cal telehealth policies. It really shows the step backward on asynchronous, and while RPM and audio only have been added for non-FQHC and RHC providers, they will be in a new category of services with to be determined rates and limitations. Next slide. Another visual that shows this compare and contrast, that while there are some new pieces, there are some new limitations. And if you think about how Medi-Cal is proposing to restrict and put all non-live video telehealth in a completely separate bucket, it really is reminiscent of the way CMS and Medicare has treated telehealth in the past, when Medicare has generally been regarded as pretty far behind in terms of telehealth policy. And with that, we can go to the next slide, and I will pass things over to head into the next section of the webinar. First, want to introduce Blanca Castro, serving as our moderator of the panel session. Blanca is the Advocacy and Sacramento Metro Manager for AARP California, and is responsible for strategic development of statewide policy priorities and leading federal, state, and local advocacy efforts in support of AARP's legislative priorities. Blanca.
Thank you very much, Amy, and good afternoon, everybody. Blanca Castro with AARP, and it's a pleasure to be here and kick this panel discussion off, which is really exciting. So the purpose for today's panel is really to discuss from the perspective of the panel speakers what the impact of the administration's current proposals will have on the different communities and populations that they serve. So I'm going to give a very brief introduction on each of the panelists before we get started, and then I will start with the first panelist. So first of all, Jennifer Alley, she's with Marriage and Family Therapists Association. She has 15 years of health care lobbying and government relations experience representing Medi-Cal providers and addressing aging issues and healthcare costs. And prior to her position at the association, she represented health plans, home health, hospice, and adult day programs. Next, we're going to have Myra Alvarez. She's the president of the Children's Partnership. And prior to her role as the president, she completed several assignments with the U.S. Department of Health and Human Services in the administration of President Barack Obama. She was a director for the State Exchange Group for the Center for Consumer Information and Insurance Oversight at the Centers for Medicare and Medicaid Services. She also was an associate director for HHS in the Office of Minority Health, and she was director of public health policy in the Office of Health Reform at IHSS. The next speaker is Dr. Priya Batra. She's the senior medical director with family and community health at Inland Empire Health Plan. Dr. Batra has joined IEHP in June 2017. She's a board certified obstetrician and gynecologist. Dr. Batra completed her MD degree at Columbia University and her clinical training at the University of California in LA. She's also completed a Master's of Science degree in Health Policy and Management at UCLA's Fielding School of Public Health. And her formal training or experience in health services is in research and implementation science, that they play a large role in her approach to improving care for IEHP members. And the final speaker on our panel is Andie Martinez Patterson, who is the Vice President of Government Affairs at the California Primary Care Association and California Health Plus Advocates, which is the advocacy affiliate with CPCA. Andie's responsible for shaping the vision and execution of policy strategy to achieve the organization's mission. She lives in California, has been with CPCA since 2008, and growing up and going to school in the Midwest. She has a master's in public policy from the University of Minnesota, Hubert Humphrey School of Public Affairs, and a bachelor's in political science from the University of Illinois at Chicago. So now I'm going to turn it over to each of the panelists, who will have 5 minutes each to briefly go over the use and impact that the telehealth will have on their constituents. And starting with Jennifer.
Good afternoon, everyone. I'm Jennifer Alley, and thank you, Blanca, for that brief introduction. I appreciate the opportunity to discuss the use of telehealth by marriage and family therapists, commonly referred to as MFTs. The bulk of providers during the pandemic, MFTs relied on telehealth, including the use of audio. This type of treatment has become successful because audio only allows those with limited or no access to video to receive treatment. There are several reasons that some individuals may have limited access, such as connectivity issues, lack of equipment, and/or privacy. And so audio only really provided needed flexibility during the pandemic for our members to provide behavioral health treatment to their patients. Some members that may rely, some patients that may rely on public transportation also had some issues with time away from work, possibly lost wages, right? That added an additional level of stress in getting to treatment. And, accessing behavioral health treatment should not be stressful, right? And so, we want it to be behavioral health to be easily and equally accessible for everyone, including those in the Medi-Cal program. And the use of audio only really provided that option. One statement from one of my members says regarding her experience with the pandemic is, now having spent time with telehealth and seeing the success, efficacy, and ease, I plan to continue to use telehealth after the crisis is over. Prior to the pandemic, I was working in 3 locations, and the use of telehealth has increased my availability for my clients. And that's just for obvious reason, right? Time spent traveling between locations. And so, the Medi-Cal proposal, as Amy, talked about, treats the modalities of telehealth differently. And we have some concerns about breaking telehealth up, especially when you talk about, access and provider reimbursement. It's just a problem to break things up. How treatment should be accessed should be left to the clinicians. MFTs, like other providers, make appropriate decisions regarding how their patients should access services, and it shouldn't be based on their reimbursement rate or fear of losing money for utilizing, one type of telehealth over another. Clinical appropriateness is a factor that clinicians take into account in their work for their clients. For example, play therapy with children doesn't necessarily work over telehealth, but discussing relational issues, isolation issues, depression, those types of issues do work very well in audio only. And MFTs, like other providers, are guided by law and ethics that governs their treatment. Several factors, and this includes several factors, including clinical appropriateness and patient privacy and consent. We really need a system that acknowledges beneficiaries' preference and provider capacity and client resources to help ensure access. The limitation of video only or synchronous, I can never say that, so I'm not even going to pretend that I can. Telehealth might act as a disincentive for providers to participate in a program where patients have issues accessing care. Because when patients, can access their care and they're not participating in their behavioral health treatment, their conditions can worsen. And in behavioral health, worsened conditions like medical, physical medical conditions have dramatic impacts on the patient. But for behavioral health, it impacts their family life, work productivity, and may result in a higher costing care, ultimately resulting in higher costs to the Medi-Cal program. And so the limited use of telehealth in the Medi-Cal program will result in delayed access to care, and will increase the number of missed treatments, which during the pandemic, there were fewer appointments were missed by clients or patients, and they believe that is because they had other options for getting to treatment. And so unfortunately, if it goes back to how it was before the pandemic, there is a concern that patients will continue to miss treatments due to various issues on getting to the appointment. And so we just think that the patient's choice should be considered, and if they need to access behavioral health treatment, by using a telehealth modality, they should have that option. And we think removing patient preference is insensitive, and that choices that are available in commercial and exchange markets should be available to all Californians, regardless of their coverage type. According to the California Healthcare Foundation, patients with low incomes and their providers agree that patients with low incomes and their providers agree continue telehealth. And some of the key findings from their surveys indicate that 79% of patients with low incomes who had a telehealth visit said that they would always like the option for phone or video. And 70% of patients who had a telehealth visit say that they would likely choose a phone or video visit over an in-person visit whenever possible. And so that just kind of, to me, was a good example about how important patient choice is when it comes to determining how they will access the care, medically necessary care and treatment. And so, obviously CAMP has some concerns with the current proposal. I don't really have any additional comments, but again, I want to thank you for the time and the opportunity to participate in the panel.
Thank you so much, Jennifer, for those comments. And the next panelist is Myra Alvarez with CH Children's Partnership.
Thank you, Blanca. And thanks for the opportunity to be a part of this panel. I'm excited to join my fellow panelists in this important conversation. For over 25 years, the Children's Partnership has worked to ensure that advances in technology benefit children and families, particularly those from low income or otherwise marginalized communities. And in particular, over the almost last decade, we've worked to highlight how telehealth in particular can address barriers to care for many of California's children. But it's since the onset of the pandemic that the work to elevate the potential for telehealth to better meet the needs of kids has grown. And it's grown exponentially in both awareness and opportunity. And I'll talk about both. So from an awareness perspective, in considering the growing need to find ways to care for children during this time of physical distancing, telehealth continues to be a critical tool in providing care to children in their communities, in their home. While prior to COVID, we know that schools and childcare centers needed increased guidance and support from the state on how they could utilize telehealth, there continues to be work to do around ensuring families and individuals are supported in using telehealth as an opportunity for accessing care. And I'll talk about this from the perspective of some survey data that's been conducted recently. We did a joint survey of about 600 California parents of young children 0 to 5 in partnership with the Education Trust West and others that told us that 94% of parents surveyed would like to access their child's doctor using telehealth, but only 48% are currently able to do so. In another survey conducted by our partners, the Parent Institute for Quality Education, and it was a survey of predominantly Spanish-speaking parents, nearly 50% of them said that they do not know how to receive medical services online or by phone. And with the greatest disparity being in the Central Valley of our state with over 50%, 52%. And then finally, in a survey that was conducted by the California Pan-Ethnic Health Network, 62% of Latinx respondents could not access telehealth because of internet connectivity issues, when it was highest amongst all racial groups. So these survey results really tell us that the work ahead must focus not only on strengthening our healthcare system to respond to the needs of California's diverse communities during this time, but also strengthening our commitment to educating and reaching people where they are. So that brings me really to the opportunity in front of us. In considering our state's commitment to building back from the pandemic, the work to strengthen the telehealth infrastructure available to Californians is obviously necessary. It's during this public health emergency that the flexibilities that were put in place have supported the delivery of care in ways that better meet families and communities where they are, especially during these shelter-in-place orders. As outlined in the governor's budget proposal, there was a much needed and important investment in these efforts, and we're grateful to the state's leadership for acknowledging that policy changes needed to be made post this public health emergency are getting, moving forward. But in response to that data that I referenced earlier, we do want to ensure that our future telehealth policies are expanded with equity at the forefront. One positive aspect of the proposal, and Amy touched on this, is that it does expand telehealth services to be explicitly included in the LEA Medi-Cal billing option program, which is particularly important for our education partners. However, I think we know that partnerships between community clinics and schools and school districts, they're a key component of success for bringing telehealth to students, to young people, and we want community clinics to be fully supported in expanding their telehealth programs as well. So building on the previous panelists' comments, we share the concerns that excluding federally qualified health centers from being reimbursed for audio-only care is only likely to exclude communities of color and low-income communities from accessing care, recognizing the challenges in obtaining the necessary equipment or bandwidth required to engage in other forms of telehealth. Additionally, we really are urging our department to amend the proposal to ensure that community clinics can establish patients using asynchronous telehealth. While during this time, much of telehealth is used at home, we know that our families, our communities, all of us are eager to go back to a different routine, often relying on community partners like schools and early learning centers and others to care for our community members, our children, and often to also provide a space for health services. We've seen, the success of the virtual dental home. We've seen the success of virtual therapy. Asynchronous telehealth is an effective way to bring care to thousands of children who might otherwise be unable to access it. And I flag this because this is especially important to consider as we prepare for the mental health impacts of this time. So we not only focus on short-term responsibilities, but also long-term. We know that it's multiple crises. It's the pandemic, it's the economy, it's ongoing racial injustice that are impacting the lives of kids in many ways, including their mental health and overall well-being. In that same survey we conducted with the Education Trust West, it's 70% of parents are telling us that they're worried about their family's mental health as a result of this pandemic. We knew this was happening even before the pandemic, as far as the presence of adverse childhood experiences and the stress of emotional distress that many children were already showing. So over the next several months, as we see more vaccinations rolled out, as we see parents and kids return to work and school, we hear from experts that children and families may begin to realize the full extent of the trauma and toxic stress that they've been experiencing because of this pandemic. And we want to ensure that as kids react to that, whether it's the behaviors they exhibit, separation anxiety, inconsolable sadness, that we have a way to respond. And schools and childcare centers are going to be at the front line of that response. So there's great opportunity to strengthen the state's response to the multiple pandemics of this time, particularly through intentional improvements in our telehealth program. And I'm looking forward to working with my fellow panelists and all of us that are part of this webinar to accomplish those shared goals together. Blanca, I'll hand it back to you.
Thank you very much, Myra, and really appreciate the focus on mental health. We're hearing a lot of that from all different ages. The next speaker is Dr. Priya Batra with Inland Empire Health Plan. Priya.
Thank you so much. Good afternoon.
Doctor.
Thank you so much and for allowing me to speak on behalf of Inland Empire Health Plan. So I'll give you a little bit of background. Inland Empire Health Plan, or IEHP, is a nonprofit Medi-Cal managed care plan, and we cover over 1.3 million beneficiaries across Riverside and San Bernardino counties. And to give you some context, that's, 30,000 almost square miles of geographic area to cover. We have a really diverse membership and also diverse network of providers. As far as talking a little bit about COVID-19 and telehealth, I think it's most useful to frame our members and providers' experience with it sort of before the pandemic, during, and then sort of like what Myra said, what we anticipate or what we'd like to see going forward. I think that prior to the pandemic, very much in alignment with our other sister health plans across the state, we were trying to optimize the use of the existing telehealth benefit as it was covered in Medi-Cal to really support and center the members and providers in our network. So we were moving full speed ahead with asynchronous telehealth where it was appropriate, especially in specialty care, dermatology, ophthalmology, things that have already, dental, things that have been mentioned in our region. We've been really working on supporting behavioral health providers in providing telehealth services as part of their routine care and getting members more comfortable with that as well. And also participating in the e-consult opportunities available through the prior policies to increase specialty access in our network. So really, I think we had a good had laid the groundwork for telehealth to really make sure that our members and providers prior to the pandemic were taking full advantage of that benefit and the payment parity that was set up prior to the current proposal. I think during COVID, we saw that laying this groundwork really paid off. Just to give you an example from our preliminary data, we went from in February 2020 to having telehealth claims and encounters in the thousands, in our 1.3 million membership to 60,000 plus in March 2020 to sustained well over 150,000 claims per month through the pandemic. So it looks like during the pandemic, we did see our members and providers really take advantage of this service that had already existed. And then we also really scrambled to communicate to our members and providers all the new flexibilities that we were really happy to see during the pandemic. That speaks to the changes that FQHCs and RHCs were allowed to implement. It speaks to phone only, audio only, right, as an opportunity for members and providers. And so that has really been taken advantage of in our membership. Took a lot of training with providers. We also expanded to help providers think about how to meet care quality thresholds using telehealth, right? How does that fit into their quality practices? Less as just a sort of emergency, use of telehealth, but how do we make sure that this is really meeting the standards that we would expect for care more broadly for our members? And then looking forward, I think like a lot of the other panelists had mentioned that, what we're seeing in the proposals may make administering telehealth more challenging. Our hope is that what comes in the future for Medi-Cal for telehealth sort of builds on the freedom and the centering of the member-provider interaction, right? The centering of that healthcare interaction, the centering of their needs, and sort of that's how the changes in the future proposal for telehealth and Medi-Cal works, right? To really center that experience and then build outward from there. And sort of allows flexibilities to support that interaction and quality care. Thank you.
Thank you, Dr. Batra. And now we have Andie Martinez Patterson with CPCA. Andie?
Great, thanks, Blanca. And thank you, May and everyone else for having us. And I will just note at the beginning, we didn't coordinate our comments, and yet we're all going to echo each other. So I appreciate and applaud all of the alignment that we have. It's really exciting. CPCA, the California Primary Care Association, and our respective advocacy associations, California Health Plus Advocates, we represent community clinics and health centers across the state of California. There are some 200 plus corporations and some almost 1,400 sites serving 7.4 million Californians across California. I started at CPCA in 2008. 2009, the High Tech Act was passed. It was right before ARA to support all the technology needs. So we have been talking about telehealth and HIT, health information technology, for over a decade. So, and health centers there's been many health centers who are deeply ingrained, who've been working with the Children's Partnership for years on promoting and advancing telehealth. But most health centers, as interested as everybody was, I used to joke that it was always on the top 5 most important things to talk about, but it always was number 5. We couldn't push it further than that. And for the most part, that was because of payment. We just could not figure out in the health center world how to make it work with the restricted rules on payment, even though we knew in rural how important it was, even though we knew for our patients who had a really hard time with transportation, who had no cars or had multiple jobs, getting to the health center was so hard. We knew it was the right access mode. We just could not figure out how to sustain it financially. So when COVID came, it was within a matter of days that we were on the phone with Department of Healthcare Services advocating. And within 3 days, I will tell you emotionally, it felt like 2 weeks of saga, but it was actually 3 days that it took us to get the flexibility in the payment with DHS, which I will commend them for to the end of time because it really saved and stabilized the safety net. But because we had been talking about telehealth for so long, health centers knew exactly how to do it. We weren't, avid pros at it, but we knew what to do and how to do it and how to move agilely. And today, health centers are still continuing 50% of visits via telehealth, and the majority of those being on telephone. There has been nothing less than a resounding success. I can't underscore that enough. With every survey, every anecdote, every conversation you have, providers love telehealth, patients love telehealth. And telephone is an essential element of it. It is the least sexy of the technology, but the most important and easiest access point for behavioral health. There are health centers who are reporting 0% no-show rates, which is no one could have ever predicted such a thing. Elderly particularly are really much more comfortable with the phone than they are with the videos, and they're clicking through, and it's much more complicated. And then rural, of course, with our broadband and our digital divide, there's just not enough data out there and plans and resources out there in the low-income communities to support the video type of visits. Telephonic has been an essential lifeline and a safety net in and of itself. And we knew 10 years ago, 20 years ago, that it would be an essential access point, and it's been proven so quickly and so timely, and we need to keep it going. Now, we knew early on that the state had some challenges and uncomfortableness with all the flexibilities and like what they would do into the future. Everyone resoundingly, from the feds down to the state, to to the health plans, everyone, we know that telehealth is important. We get it. It has proven to be more successful maybe than we all thought it could be, but we're going to have to put some limits on it. That's what we were getting the message. So CPCA, along with a number of other association partners, were working on a piece of legislation early on, knowing that we were going to really need to solidify the permanency and the flexibility of the flexibilities that we had during the pandemic in AB 32. And particularly this matter of payment parity. I think Jen Alley spoke to this. You do not want to knowingly create a disincentive for a provider to an access point. So to pay less for a telephone visit because Medi-Cal as the payer finds it less valuable, even if the patient finds it more valuable, creates a disincentive for a provider to require patients to come in, or to have less telephonic visits and more in-person visits because they have to sustain payroll. We don't want to intentionally create bad policy. And then, of course, I'm happy to go into, and then, of course, the other thing I would just say about that is, in Medi-Cal, very different than commercial, as I'm a Kaiser patient, in large part because of the IT technology aspects of Kaiser. Because I had a different model before Kaiser coming to Cal. I was noted I was from the Midwest. Kaiser's ability to have the patient portal, the telephonic, I'm a mother too. I have definitely used the telephone to call the nurse advice line to save me from an ER visit with a fever that was too high. The fact that we only enable, commercially insured individuals to have access to that, to decrease their stress, to decrease their time at the emergency room, but we do not enable 13.5 million Medi-Cal low-income people who have trouble with transportation, which we acknowledge, have trouble with maybe language access, financial resources, and then we penalize them by saying you don't get all the access points that everybody else does is an abomination and is a massive equity issue. So we are pushing really hard on permanent flexibility, payment, and parity, and are really excited about it. And I am excited to answer lots of questions. There's a little bit of a nuance that I won't get into. Maybe we can do it in the Q&A about what it means to have health centers not get paid at all for the telephonic. I'll go into that in a little bit later, but that we are fighting for our patients. This is really about equity for the patients, and every mother and family and anyone with a child who has ever had to worry and gets to pick up a phone and gets that ease immediately quelled. I'm fighting for all those people and trying to get the parity for telehealth. So excited that we are here. We are closer than we have ever been before to something that we've known for a long time. And just like Myra, really excited to work with all of our partners here to get it done. Thanks.
Thank you, Andie. So now we want to just open it up for the panelists and have a round table, and we are also taking questions from our audience. And the first question we wanted to pose, many of you already talked about this, but there has been, without you all aligning together before it was very interesting. You all talked about how audio is very important, or telephonic. So there's been a lot of discussion around whether to keep it around or not. So what would happen, and you've all touched on this, but what would happen, the impact to your constituents if telephonic access were removed because of this proposal? And then if you could also touch on, there was a question from the audience, on whether or not you have any insights on whether texting, especially around the mental health supports, was a critical communication channel during the pandemic. So Jen, do you want to kick it off? And please, this is a roundtable, so if you want to just raise your hand and jump in, I'm encouraging panelists to do that.
So texting is a tool that our clinicians report utilizing, not necessarily for specific treatment, but just as appointment reminder, maybe a brief check-in. But I don't think that it's really necessarily a modality that is like an intervention that would be used or considered, a clinical care modality. And there's just a lot of unknowns with texting regarding, is it really a modality? So there's some ethical questions there about, would it really be, a reasonable to consider it a treatment other than just a brief check-in? And there's some privacy, concerns with utilizing that. And so, there's possibly some sort of future hybrid clinical texting, but I'm not aware of it being done now. And as for the other part of your question about, audio only, the loss of audio only will have a significant impact in behavioral health. And I'm not aware, and maybe somebody on the panelists can educate me, but, for, the use of behavioral health in general grew significantly during the pandemic. And audio only was a part of it, but for the Medi-Cal beneficiaries that, began behavioral health treatment using audio only during the pandemic, what happens to them if their treatment modality goes away? Do they have to find a different provider? Is there frequency, if they're doing it once a week or every other week, is that going to have to change just, due to limitations on their ability to get to their provider's office or location? So I just kind of that's a question that I have, but definitely a significant impact. I think decreased, compliance with appointments or not attending, no-shows, which impact the providers as well, right? When somebody doesn't show up for their treatment, they're not reimbursed for that period of time. And so, but also, conditions will worsen. And so obviously we have significant concerns.
Thank you, Jen. Does anybody else want to address that on how it would impact, especially Medi-Cal low-income clients, if audio were removed?
I can add, just building on Jen's comments, and before I'm sure my fellow panelists will talk about it from the provider perspective, but just in thinking about the conversations that we've heard from our community partners, the surveys that have been conducted of families with young children and families more broadly, having multiple ways to connect with a healthcare provider is critical at any time, but especially in a public health emergency, and especially when we know that there isn't equitable access to all forms of modalities, right? Or internet. I mean, the reality is that until we can assure every Californian the opportunity to access services via telehealth, via the prescribed methods, whether it is, synchronous or otherwise, we have to provide other opportunities for people to get the care that they need. And that conversation is broader than just let's make sure we reimburse for audio only, but really speaking about what sort of system are we building to ensure we're responding to the needs of our diverse communities, and the reality that we have work to do. right? We have work to do, and we're not expecting everything to be done immediately, especially as we rebuild back from a pandemic. But in the meantime, can we be flexible? Can we be open to finding ways to ensuring our families get the care that they need? For many families with limited English proficiency, with limited incomes as a result of working many of the frontline jobs that are keeping our economy running, it's a luxury to have internet. It's a luxury to have a laptop or a smartphone that enables them to connect with their provider. And audio only presents a safe, accessible way to access their providers, particularly their community clinics that are trusted, that speak their language, and that give them the care that they need. So I think that we can't have this conversation from a narrow perspective. It really needs to be within this broader context that enables us to consider the many aspects of a more equitable healthcare delivery system.
That's absolutely right. And just to add from that, I can speak, to audio only. I think this is a very important topic, and I'd like to speak to, I can speak to it from, the data that's out there, which has already been cited. I think someone talked about the CHCF survey report, which showed that most low income individuals like audio only and have used it, right? So that is a number that we know. I can say that from our health plans perspective, we offer, I think Andie was talking about, like, we offer a nurse advice line and then like a online physician after hours telehealth service. 90% select phone. There's a choice between phone and video. Almost everyone selects telephone. So I have, we have some data from our health plan to support that there is a desire for this to be available. And I'll say that as a provider, so I volunteer, I still see OBGYN patients, pregnant prenatal patients in the office. And there is, sometimes phone is appropriate. And also it's not like an either or. I think some people see it as an in-person visit versus audio only or versus a video visit. I find actually that you can use, a telephone visit to do an intake to set yourself up for then an in-person visit that's much more focused, or a video visit, right? If phone is not appropriate. And I think that clinicians over, the pandemic have really learned how to integrate this as like an additional service in the menu of services available to Medi-Cal members. So I think a lot of the tension around expanding these services, maybe comes from this idea that we're replacing one thing with another and that it's not as good. But actually, these are all services. I think, Andie, your story was really great. You can call the nurse advice line and get everything resolved, or you may call it and need an in-person visit and need it urgently, right? So it's just creating more, there's like that no wrong door idea of how to get into care. And then trusting that, our clinicians are using their clinical judgment appropriately and offering this menu to everyone who could benefit from it.
And Blanca, to the question on what's going to happen, like at F2HCs, if there's no payment for telehealth, or for telephonic, there's not going to be a lot of telephonic visits, and that's a travesty. And we don't get to say, well, you have the option of video. Rural folks say, I don't have broadband, so I actually have no access point that way, and I'm now going to have to drive a few hours to get to you. That's a challenge. Health centers likely, I'm gonna, as they do, just similar with behavioral health, they will provide access if they know their patients need, but they cannot wholly sustain it unsupported. And from what we found, for the most part, telephonic requires the same level of staff and support, so it's not cheaper necessarily. I do believe probably in the long term, you could figure out how to make it cheaper than an in-person, but that also assumes that you're reducing capital expenditures on the back end, which no one has done at this point, right? We still all have our buildings and our infrastructure, and we pay heating and air and all of that, even if nobody shows up. So it's the same amount of money. And if it's determined, to Dr. Bosser's point, you have to come in for a visit, right? Or a well child visit. We've tried to figure out how to do drive-through well child visits, right? Where you can do maybe some immunizations, but you also, some of that can be done on the phone, but some of it has to be done physically. We know that it hasn't, we've heard a lot from DHCS that they're concerned at how slowly it's picking up again on the well child and the immunizations. And we're concerned too, but because of social distancing, you can't let a family who's got 4 kids come at the same time. You can only have 1 kid at a time, and there's no childcare. So, and it's not, deathly urgent to get in those visits and those shots. It's more important to stay at home and to be socially distant. So those are, separated, and that will be for a little bit of time. But we're all we're learning this new modality and this new access, and to cut it off right when we're learning it seems such a detriment to the entire system. And I will flag CPCA immediately saw, because we've been talking about this for years, that we needed not only to do telehealth, but we also needed to change the payment modality. So we are working with the state to do what we call value-based payment and alternative payment methodology that I hope, I say it out loud, may the stars align and God be with us, January 23, we'll kick it off, which would mean that you get paid effectively the same amount, no matter what type of access you provide. Maybe it's a phone call, maybe I'm emailing with you because I love emailing with my providers. Maybe it's an in-person visit, but you get paid the same no matter what. And we know that that's what really makes a difference. So to Dr. Batra's point and Jen's point, it needs to be the clinician that decides what's the best way to do it, as well as the patient saying, this is most comfortable for me. This is most impactful for me. That gets to count in the value equation too.
And so what we've heard from many of you, and I was listening to your responses, you've touched on the flexibility that is needed. You've touched on the different modalities that should be an option. And so my question, our question now is, because you've also touched on, each one of you have talked about what you have either intuitively seen, where it's been an increase in the number of patients that are using telehealth. I think it was Dr. Batra who said almost 60,000 in 1 month, went from several thousand. So you're using a lot of some of this data. So how we hear that the data and ensuring we understand who's using telehealth, how it's working. Do you have any thoughts on surveying your patients or studying the use of telehealth under this emergency expansion to better inform policymakers as they're looking at this particular proposal, any other ones that would address many of the things you've talked about?
I can speak a little bit to that. So I mentioned we're now starting to build dashboards of our claims and encounters that we're receiving with telehealth codes, and there's limited specificity still because of the way it's built. So we're very interested now as a next step into looking at geographic variability first. We have, I mentioned we have a huge geographic area to cover. Our high desert, San Bernardino region, like Barstow, Victorville, like those outlying areas where access has been an issue, period, right? Provider, the adequacy of the network is tough to maintain. And our low desert, like out towards Indio and the Coachella Valley. So it'll be interesting to see next, are there, someone spoke about equity earlier, like, are there areas which are using this less or more? Why is that? So sort of digging in with surveys and additional interviews once we see what the data looks like. Language preference is also an incredibly important issue in terms of equity and access. So are we seeing differentials in use by language preference? So I think that's definitely of interest to me as we look to sustaining this. And then we're also, we also, even prior to the pandemic, thought that telehealth could have real benefits in these outlying areas just from talking to members about transportation issues, childcare needs. And so using this data then to do some focused, funding opportunities for providers to build a little bit of capacity. I think a lot of our providers have learned how to do telehealth sort of in this emergency situation. So it'd be interesting to see how we can support that capacity going forward. And then, we're doing some thinking, some pilot programs around, how can we use medical equipment like DME requirements for things like blood pressure cuffs and scales, like to support telehealth, right? Because we heard from some of our members, this is interesting to me, but I'm not really getting an exam. Doesn't feel real, right? So how can we use existing Medi-Cal benefits to really support this practice and make it feel like a better experience for the members and providers? So I think looking at the data from like an equity perspective will be interesting. Looking at, different groups that could use a little bit more of a push to sustain this going forward. I think that would be, how we'd want to use the data next.
Thank you, Dr. Batra. Anyone else want to touch on that?
The only thing I will add is obviously we don't have patients, but I do think that many of us are eager to see the results of the California Health Interview Survey, which is a very robust survey that the state of California has supported for a very long time and is a unique addition to the field, nationally at least. And the last survey that they did around telehealth utilization obviously demonstrated sharp inequities in access to utilization of telehealth, particularly for limited English proficient populations. And that was, I think, like a compilation of 2015 to 2018 data. So really thinking about what the pandemic has done to exacerbate those inequities will be interesting to see. I know they'll get in the field soon and be able to share that data. So I think many of us are eager to see that. And then to the extent possible that organizations such as ours, such as our partners like BICE or EdTrust West or CPEN, they are conducting surveys to, again, to the extent possible, and are demonstrating, the challenges in accessing telehealth, that there is great interest and people are eager and excited to engage, but that there are limitations that are beyond their means, their ability to control that. And that, again, just links to the structural barriers that populations face in accessing their healthcare that we need to consider when reforming or improving our delivery system, particularly in response to the pandemic.
Thank you, Myra. And here, I think is something that you can all touch on, and you've all talked on some of the disparities, but for example, in ARP, we did a survey in 2020, and people 65 and older, over 40% of the survey respondents said that they didn't have a computer or they don't know how to use one. So what are other issues, such as the digital divide, that you think contribute to existing inequities? You've all touched on this. And what do you think policymakers should do to address them? So explain how telehealth and the DHCS proposal ties into those issues, if you will.
Well, we think they should sign AB 32. I think that's the first thing.
Good.
It's parity, its ability to enroll and be on Medi-Cal via distance, as opposed to having to be in person, which is, the Medi-Cal program, in order to, I think the good intention is to protect taxpayer dollars, tries to be very rigid and, prescriptive with how things are done. But they are built from a bureaucratic mindset, and not from somebody who's there's so many, we all know about ACEs, we all know about social determinants of health, and yet we continue to perpetuate systems that exacerbate them. And COVID showed us that we don't have, it's not because we don't know how to do it differently, it's because we're making a choice. And we need to make a choice to go in the other way. And we have to stop talking about, we all care about equity, but we continue to further inequity by our policy decisions, which we know are wrong. So paying for it, at the very least, we're aware, we're not trying to get fee for service till the end of time. We want to reform the payment methodology. Telehealth is just one piece, right? Telephone is one piece. We need to move to page reporters where we're emailing. We need to move to a place where providers and plans are working together to provide the resources. In lieu of services are coming through CalAIM, enhanced care. There's so many things that we need to be doing to integrate our systems, not preventing our patients from having the best, easiest access possible to them. Parity is a part of that. If you pay someone more money to give, I'm sure Dr. Batra can talk about this, for a C-section, there's going to be a lot more C-sections. If you pay somebody more for, having a live birth, that you're going to get more of those. We know these things are very basic. So those parts, and then we need to figure out how to do the last mile, digital divide. And we need to subsidize access, having access to the internet, good internet access, one that doesn't time out all the time, is now as important as water, clean water and clean air. You're limiting education and opportunity to people, and a number of other things. Other people, this is not my area of expertise, but just on principle, we all know this. So sign AB 32 and give you the letter so everyone can get on board with that. And then we need to subsidize broadband. We need to help provide that. And then we also need to provide support for all of the things like blood pressure cuffs at home and scales. And then we need to digify them. And then we put them on the patient portal, and patients can be monitoring their health at home, feeding it to the providers. And we can be looking at, once we learn how to look at all that data and integrate it, we can be wrapping it around the social supports and services so patients can be more in control of their destiny, than our being in control because we get paid in a certain manner.
Thank you, Andie. Dr. Batra?
Yeah, I would add to that. I think that's totally right. I think, thinking like sort of like large, high level to the provider member level is really important. So infrastructure, right? Sort of, I think we saw that digital divide in education too during the pandemic, like who could learn well online and who couldn't, right? So it's the infrastructure, it's the hardware, that's a piece of the investment, like having that laptop, having that tablet. And so I think that's from the member perspective. But I think the only thing I can add to what Andie said is on the provider perspective too. So they really needed to jump into that infrastructure for video visits, and they were scrambling. We were providing lists of HIPAA compliant platforms and, helping them understand, how do you consent someone for this? I'm sure, Jen can speak to that too, right? It's like, you have to learn that and you have to build your capacity too. Workflows in the office. I think Andie mentioned as well, like you still need your medical assistant, you still need your intake done. How do they understand this new workflow, right? So I think also investing the way we sort of thought about EHRs 10 years ago now, like that was like a new investment, right? From a provider capacity perspective, I think this is something to think about that way too.
And the only thing I will add, Blanca, if I can, is
Yes.
in some of the questions that have come up is, where is the opportunity for advocacy around these issues? And I think the pandemic has really highlighted just how intersectional many of these challenges are for families and for many of us that are working, whether it's in healthcare or education or broadband infrastructure alone, just how shared the struggles are and the opportunity to engage in each other's advocacy efforts in order to strengthen a system for all of us. Right there, like as we strive to ensure we strengthen access for low-income families with mental health care, for example, it's the same families that may be struggling with their child's learning capacity because of the same broadband issues, right? Or it's the same families that are having difficulty accessing, high-speed internet because of where they live. So thinking through how this is an opportunity for us to really break down these silos in our sectors in order to strengthen our systems overall, whether it's our healthcare system, education system, broadband infrastructure. So there's a glimmer of hope in thinking through what the possibility is for the future.
Yeah, also just, the same populations that can't access vaccine appointments. It's all like linked, right? This is all,
Right.
Myra, yes, it is the same story again and again, right? So can we invest in this? Because we're also kind of future-proofing the next, the next emergency, the next gap, the next problem, right?
And very, very great roundtable. And I have a couple more questions, and I want to also be mindful that there are questions from the audience. But we've talked about disparities. We talked about the digital divide. And I think it was Dr. Batra that you shared one of the best practices. So are there any particular clinical workflows, triage, or other best practices that have been implemented during this pandemic, but that the DHCS proposal would limit? So if we can talk about, what have you already been able to do because of the expansion? And now if there's going to be a limit, what's going to prevent that from some of these best practices?
Yeah, I can speak to that. I'm interested to see what other folks have as far as like clinical guidelines. So as I mentioned before, the sort of as it stood prior to COVID, policy really relied on the clinician's judgment about what was appropriate for telehealth versus in person, what was, what modality was appropriate, right? And so I think that is sort of how this should be centered going forward as well. There's no one size fits all. And this is true prior to telehealth, what's managed in urgent care versus, right, that liability, that clinical decision-making is really with the clinician. So from a payer perspective, when this all started, some of our providers reached out to us and said, is it okay if I do a telehealth visit for, post-discharge? And my question would be, well, what was the admission for? Like, do you need to, do you need to do an exam, right? It's very specific. For some, yes, some no. So I don't think that, from a payer perspective, even when we do, we're in managed care, there are utilization guidelines for certain specialty services or procedures. I think that the modality that the care is provided is much more difficult to determine, like on a very black and white basis. So I think what's made it successful so far, the use of telehealth and Medi-Cal, is that it's driven by clinical need, just like it is in the commercial, like, you know, for anyone, right? It's driven by clinical need. That being said, I think what we have been able to provide guidance on is how do you provide real like screening services? Like there has been some guidance from some of our accreditation bodies like NCQA, right? Are there certain screenings, like a depression screening? That's a quality measure that's really important. Can you do that via telehealth, right? So where we can get guidance from other like national bodies, we're happy to provide that, you know, around some specific quality services. But I think, you know, really it's on, you know, clinicians to determine what's safe and appropriate for that particular member in the particular system they have, right? You know, the other thing to think about, I think we talked a little bit about not just broadband access, but in some communities like cell phone numbers, things like that like turn over all the time. So is this a safe follow-up to do via telephone or telehealth? You know, if you're worried about, if it's really critical, you're worried about the return, maybe that's something to schedule differently, right? Or so I think, you know, I'm hesitant from the payer perspective, at least from our perspective, to put out really very strict guidelines about what modality is used for what need. So I don't know if other folks have thoughts on that.
Okay, best practices. Jen, did you want to? Okay.
No, I don't necessarily have anything to add, but I think that her comments were, you know, right on point. It is, you know, at some point a little bit, you know, it's a clinical decision on how treatment needs to be done. And so there's the clinical aspect. And then of course, you know, it's the patient perspective on what they need and what they want, right? They may want an audio only and you're like, no, you need to come in, right? I mean, it's going to vary. And so, you know, it is important not to develop policies that necessarily prohibit the patient choice, but you know, also include the clinician's perspective.
And also just like one of the sort of principles prior to COVID in the Medi-Cal kind of policy around this was that a member needs to understand that they're getting telehealth for a specialty visit, let's say. So if a referral is made, there really needs to be a sort of bidirectional understanding that both parties think that's appropriate and want that. So it's not just, it's also making sure that face-to-face is available when it's needed or when it's desired.
I think it also just want to underscore that if payment was all the same, then you want the patient to choose that, right? Because it's highly possible that you show up I've shown up at a doctor's office with a cough for 3 weeks saying this can't possibly be a cold, and the doctor looks at me like, you're wasting my time in this physical visit. Like, yes, it's a cold, you know, like come back in 8 weeks if you haven't gotten rid of it. That was a waste. Like I could have just called the nurse and said, hey, I just don't understand my cold, right? That's, if you were paid the same, then let the patient decide, and then the provider can say, oh, you can quickly do it over here. Oh, actually, you can do it via email. Send me a picture. Send me a picture of graph. That's not a big deal at all. That takes 3 minutes. I mean, there's so many. If we look at value-based, this is our opportunity to pay differently. Fee for service is what is putting the restrictions on all of this. And it could be solved. I mean, value-based payment is not simple, but that is what we should be expending our energy on, rather than maybe you should only have 4 telephonic visits, or maybe like all these silly iterations of it. We should just pay differently and then let the patients and the clinicians do what they know how to do.
Like they've been doing all this time. I have another question here, and then May, if you want to open it up for the audience, additional questions. But here is if any of you could speak to this on how telehealth fits into and benefits non-traditional sites of care. So we've talked about the home, we've talked about some of the areas now that people are receiving, but are there any other non-traditional, as children start to go back to school, or now that we're opening up nursing homes? We're going to have to wrap up here because we are at time. Thank you. But I'd like to just pose that to all of you. Are there any non-traditional sites that, especially given what we've seen in this pandemic?
I know we're running really short on time, Blanca,
Yep.
but absolutely. And I think it really highlights that we're not done with working on telehealth and making improvements to our telehealth infrastructure with this effort this year, right? I think we need to continue to invest in the necessary changes to ensure we're being responsive in our approach to delivering healthcare. We as children's advocates in particular are interested in making sure that our schools, our childcare centers, other early learning providers, other community sites also have the opportunity and capacity to deliver telehealth, often obviously in partnership with community clinics and other providers, with the support of health plans, but finding ways in which we can bring care to where people are that often have internet access, that often have the technology that's available to assist people in getting those services. This is particularly important for children with special healthcare needs, for other marginalized communities that really need the support in accessing telehealth in order to access the care that they need. So I'm looking forward to ensuring that the advocacy coalition that has created so much attention to these issues over this last year will continue working together to ensure that the necessary changes in the future are made to be responsive to, again, the needs of our diverse communities.
Thank you, Myra. And we do have to wrap up. We're on time. And I just want to say again, with great deal of gratitude, Andie, Myra, Dr. Batra, and Jen, for your participation, for your insights today. I'm going to turn it over to May to close it up. And thank you all very much for this wonderful opportunity. Don't forget to get the lobbying for passage of AB 32. And we need payment parity, flexibility, and telehealth needs to include telephonic or audio also. May?
Thank you, Blanca. And let me add my appreciation and thanks to Andie, Myra, Jen, and Dr. Batra as well. And also to you, Blanca, for your wonderful moderation and facilitation today. Thank you for doing that. Robbie, if you could pull up the slides for us, please. Just a little bit of information for you. I know we're slightly over, but that hopefully you'll be able to stick around for just a couple more seconds here. Please know that, again, today's webinar was being recorded. We will have that posted within a few days on the coalition webpage on CCHP's website. If you are interested in being a member of the coalition and you are not right now, please contact CCHP staff and we'll be more than happy to let you know more details about the coalition and to add you to our list. We also want to thank the sponsors today for today's event, the California Healthcare Foundation and CCHP as well. Thank you again to our wonderful panelists, our wonderful moderator, Blanca Castro from AARP California. Thank you to the entire Telehealth Policy Coalition for your work and efforts in this work around telehealth policy. We could not do it without you. Know that you will receive an evaluation after this webinar. It would really help us if you fill that out. It's very quick, just a couple of questions. But thank you everyone for attending today. Have a great day and stay safe.